So that is sort of the medical management of hemorrhoids. We talked about, fiber, avoiding constipation, those kinds of things. So once these treatments don't work, once you have patients that are starting to have more symptoms, all this fiber, they've tried some Miralax, and they're still having situations, that's when we think about more therapy, hemorrhoidal therapies. And the whole idea behind the hemorrhoidal therapy is, again, hemorrhoids are normal tissue, but they're often, dilated and you have more tissue around it. The whole idea behind these therapies is to remove some of this excess tissue. But with that, you often are causing damage, or you're basically causing damage to the tissue, and the resultant scar that forms after healing of your therapy is a lot of the reason why this works. Yes, you are removing some of the tissue, but it's really the scarring that occurs after you cause the damage that then we think brings back some of that connective tissue that keeps these structures from getting dilated again and getting sort of engorged and enlarged again. There are I'll say three main hemorrhoidal therapies out on the market right now. There's probably actually 4 or 5, but the three main ones are rubber band ligation, which is one that we do at CTGI. There's sclerotherapy, which I don't think actually anyone in the area does. You actually inject this sort of mixture into the hemorrhoid, and it causes it to sort of solidify and harden. And then infrared coagulation, we used to do this. Actually, this was even before I started in the Farmington office. But with the use of rubber band ligation, we've sort of decided to sort of stay with that in terms of therapies. So rubber band ligation. So there's actually many different ways to do rubber band ligation. Rubber band ligation is just sort of the general treatment for it. There are different ways. So surgeons do it a different way than we do it. There's some that do it under anesthesia. We do a specific kind of rubber band ligation. It's through a specific ligator. There's a couple ligators out there that do it sort of this way. So that's the main one we'll talk about. The other types of ligation, again, include like visits to the OR or preparation, those kinds of things. So we do a specific kind of ligation. So basically the idea behind the rubber band ligation is basically we take a rubber band and we place it at the base of the hemorrhoid. And what that does is it causes that tissue to basically die off. You restrict the blood flow to the tissue. The tissue then becomes necrotic, and that usually in about 3 to 5 days, the tissue will sort of fall off and the band will fall off at the same time. And then again, as I mentioned earlier, there's an ulcer sort of that forms, and then it's the scarring as our body heals that will set in after a week or so that actually will lead to improvement of the hemorrhoid. We're not, and this is the thing, we're not getting rid of hemorrhoids because you can't really get rid of a normal tissue, right? But we're not. I mean, the only way to really definitively treat hemorrhoids is surgery, but this definitely shrinks the hemorrhoid and it decreases the size of the hemorrhoid itself, and thus the symptoms become less bothersome. So, I mean, here's a little pictorial of what we do. So basically, not to go into too much detail, but there are 3 main columns that everyone has, and so we generally like to treat every column to make sure that any excess tissue is decreased. So patients are generally usually placed in the left lateral cubitus position, so they're laying on their left side. Oftentimes we will perform an anoscopy. So I generally do one during my first visit to just get a sense of the size of the hemorrhoids and what we're dealing with. It's a pretty simple procedure. We basically bring this hemorrhoidal tissue within the ligator, as you can see there, and we just slip a band over that tissue. So it's actually pretty straightforward. It's actually it's a simple in concept procedure. We'll monitor the patient for about 5 to 10 minutes afterwards. And that's mainly just to make sure that they're not in too much pain or discomfort. And sometimes we can adjust the band. I'll go into that a bit. So, hello. So some key points so again, and now we're sort of going into why we like this as opposed to other types of therapies. So it's very effective in symptom management. So 90 to 95, there's some studies that say even 99% effective in treatment in symptom management. So patients will no longer be itching, no longer be irritated, the bleeding will stop. The complication rate is actually pretty low. It's quoted as less than 1%. The main complication people actually have are more bleeding. So sometimes you'll have actually a little more bleeding with the procedure. It's uncomfortable. It's relatively painless though. You know, we'll say, you know, it's uncomfortable. Most people are uncomfortable already. But generally it's really painless. Now, some of the other procedures out there have more pain associated with it. We like this because it's really a well-tolerated procedure. The other reasons we like it, there's no prep. You don't have to do an enema. You don't have to do any, you know, bowel prep or anything like that, because we're working in an area that's, you know, easily accessible. You don't need to, you know, have any preparation. It's very quick. The procedure itself is less than a minute. So really, you don't really need to sedate. I mean, going through sedation and all that for a procedure that's so quick, you don't need sedation at all. There are some patients that are, you know, really want sedation, or really, you know, the idea behind it. And, you know, if it comes down to that, I generally refer them to a surgeon, because we don't really have a way to do this under sedation. But I generally I haven't had a patient in the last 10 years that I have not been able to do because, you know, they did not tolerate the procedure itself. So, so what are some reasons we won't do it? Well, pregnancy, of course, is one of them. But the two ones that I do want to touch on, you're very cautious in patients with IBD. You know, if the issue isn't hemorrhoids, if it's actually inflammation of the lining because their IBD is flaring up, you do not want to put a hemorrhoid, or you want to cause more damage to that tissue there. So you have to, I'm very cautious in patients with, you know, history of Crohn's, history of ulcerative colitis. The second one there is portal hypertension. So even cirrhotics. So cirrhotics I worry about too, because they can develop different conditions in the rectum that actually are contraindications to putting a rubber band in. So those are the two patients that I sort of pause before I even consider. And then we'll, you know, go to different lengths to make sure that it is safe to do those patients. Two main precautions, they're not really contraindications, but precautions. One is anticoagulation. So if the patient's on Coumadin or Eliquis or any Plavix or anything like that, it's generally, most of the providers don't, just given the increased risk of bleeding and complications afterwards. The band itself is made out of latex. So we have bands that are non-latex. So anyone with a latex allergy, you just have to more be aware of them. Those bands really aren't as good, but it is a good alternative to using the standard band.